Good afternoon. I didn't quite expect that people would stay for the last talk. Anyway, I've prepared something. I'm from North Shore Hospital. I'm one of the intensivists there. And now we're going to talk about what's happening immediately after the mitral valve operation, basically in the first few hours and probably a couple of days after mitral valve surgery. Typically, the patient who comes after mitral valve surgery goes straight from operating theater to the intensive care unit. And of course, there, the patient and the surgical team is always very much welcome with a very big smile. And in fact, most of the time, after a few hours, the patient would get extubated, and after 48, 72 hours, he would normally get discharged to the ward. And that's a very nice outcome, during which time the intensivist can continue smiling and posing for the nice picture. But unfortunately, as you know, mitral valve surgery remains a high-risk procedure in high-risk patients. And certainly there's a number of cases where the smile's not going to be kept for a very long time on the face. And this is really what intensive care is about, is to recognize that there is a potential for a lot of complications. And really that's the reason for ICU, to monitor, detect for the potential complication, and eventually trying to prevent or to treat those complications. Those complications, they're about organ dysfunction, eventually multi-organ dysfunction, but they're also about iatrogenic problem, about all the drugs that we give to the patient and all the invasive interventions that we initiate, as well as postoperative pain management, but also all the chronic health problems that the patient brings with him when he enters operating theater. The aim, obviously, is to drive the patient toward an early extubation and recovery, preventing further complication from prolonged ICU situation. And in fact, many of the interventions that we will plan, they are preventative, really trying to optimize peripheral perfusion and avoid end organ damage, and avoid end organ compromise. And a lot of this is in fact unfortunately guided with very limited or even no evidence at all. And most of the targets that we used, in fact, they are very poorly justified targets. But let's take the example of a clinical case scenario. This is the case of Mr. LD. He's a 67 years old patient who has been suffering from symptomatic severe mitral regurgitation. And this is from a prolapsed leaflet. He's got an underlying cardiomyopathy, probably mild to moderately dilated, with an ejection fraction estimated around 45%. He's also got a history of AF, that's just rate control, and he's proposed to have a mitral valve repair surgery together with 2 coronary artery bypass grafts. And he consents to the procedure and gets taken to theater. Inotropes seems to go pretty well. At the end of the procedure, the mitral valve seems to be repaired successfully. The patient seems to wean off the bypass pump quite easily, and the anesthetist at the end of the procedure performs a TOE and comments that the left ventricle systolic function looks quite good and that the mitral valve function is very satisfying. There is only mild mitral regurgitation, and there is a transvalvular gradient that is low, basically verifying that there is no iatrogenic mitral stenosis. So what happens next is that the patient is obviously taken straight to intensive care. He's hooked up to the ventilator and all the monitoring device. But very rapidly, one of the first problems encountered is a high drain output with very fresh-looking blood in the drain and a drain bottle that fills up very quickly. Bleeding, unfortunately, is a common complication after cardiac surgery, and there's obviously a number of multiple reasons for that. This is likely to be the combination of low temperature, postoperative hypothermia, as well as hemodilution because the patient has received a lot of fluid during the bypass, but also consumption, coagulopathy, platelet dysfunction from the platelet being exposed to foreign membrane from the bypass pump, as well eventually as preoperative drug and preoperative antiplatelet medications that maybe haven't been stopped early enough. Or in some other cases, heparin effect, a rebound heparin effect, because heparin gets released subsequently from scavenging protein and sites. And then at the end, there is the very remote possibility of a surgical bleeding, but I guess it's very anecdotal, and we never really see that. Anyway, the approach to postoperative bleeding can in fact be quite frustrating. Usually the lab testings that we've got, the traditional coagulation parameters, they provide unfortunately very limited information, and we end up transfusing a lot of blood products in a rather blind way. And there is a trend now to try to incorporate into the ICU management much more functional testing of the hemostasis, and to use a much more targeted and much more point-of-care approach. And this is what things like the thromboelastography or thromboelastometry actually propose, and they're in fact quite well known from the perfusionists and the anesthetics from the operating theater. The principles are quite simple. Some mass rotates inside a blood sample that starts to clot, and as the blood sample starts to clot, the resistance to rotation actually increases, and then decrease again as spontaneous fibrinolysis occurs. All this is represented in a sort of a sausage graph, and the shape of the sausage graph will change and be characteristically altered depending on what part of the coagulation pathway is in fact abnormal. And that helps us, or presumably there is a hope that it would help us to respond to the coagulopathy in a much more targeted way, and that eventually better justify the future use of factor concentrates, for example. But the point here is certainly not to discuss the detailed aspect of the management of postoperative bleeding. It's simply to present how those patients with fragile ventricle, who have a very reduced reserve and can poorly cope with highly fluctuating circulating mass, they end up being exposed to a lot of fluid and a lot of blood products. And there's certainly a lot of problem with blood transfusion. Certainly there is the problem of fluid overload and fluid shift, but also there are direct other indirect effects, such as lung injury, which is transfusion-related lung injury, or other problems such as immunosuppression and maybe an increased tendency to delay problems such as infection. Those issues are part of an effort to be addressed in trying to improve the quality of the blood products. I mean, leukocyte-depleted blood products are now mainstream, but there is a hope that investigating things like using much younger packed blood cell as opposed to much older packed blood cell may also improve and also result in improved outcome. Talking about blood transfusion, and before we move on to a more cardiological aspect of the postoperative care, when we talk about blood transfusion, once the patient is not in the hemorrhagic phase, and basically the transfusion is not indicated for hemorrhagic shock or active bleeding, then the trigger for blood transfusion is now anemia. And that's a completely different question, obviously. And the risk-benefit of blood transfusion in this situation is becoming even less clear. It's actually a very important question, because there's a lot of disturbing evidence from a lot of different clinical situations that actually suggest that blood transfusion is potentially harmful, and on the other hand, that using a very restrictive trigger for blood transfusion is actually safe. And certainly, this is one of the areas where there is a lot of room for improvement. Basically, there's probably an association with the less blood products you receive, and the better is going to be your outcome. And that's what is being addressed with large trials such as the TRIX trial. Anyway, back to our patient. He stopped bleeding. He didn't have to go back in theater, and his drain output has now stabilized. But the problem is now that his noradrenaline requirement is going up to maintain his blood pressure. That's obviously a fairly common problem of cardio-circulatory failure or acute cardio-circulatory collapse immediately after the mitral valve surgery. And the way we approach that is actually quite simple. It's a very physiological way, thinking that blood pressure is a product of cardiac output and vascular resistance, and therefore that there is circulatory collapse either because you've got decreased peripheral vascular resistance or decreased cardiac output, or a combination of both. The first case, obviously those two case scenarios are require completely different treatment. that basically don't go well together. But the first case of vasoplegia is actually a very common issue. And this is what we see commonly after major heart surgery because of the development of inflammatory response. This is SIRS, large systemic inflammatory response syndrome, and we certainly see quite a few patients who've had long bypass time and complicated surgery come up in a very profound vasoplegic state that require a lot of vasoconstrictors. The other case, the case of a low output, it's very convenient to think of it as a stroke volume being a factor of preload, afterload, and inotropism, because all of those can be targeted quite individually in terms of treatment. And there's a lot of reason for the ventricle to have an inotropy problem, basically for the ventricle to fail in the immediate post-op period as soon as a few hours after the operation. Very often there is obviously pre-existing cardiomyopathy, but on top of that, you superimpose problems such as myocardial edema, which invariably occurs after a bypass run, but also maybe inadequate myocardial perfusion, some degree of myocardial ischemia, either because of impaired coronary perfusion or because there is an associated procedure on the coronary arteries, or because there is a true coronary event such as a clot or an air bubble embolus in one of the coronary arteries. But also, and which is quite typical of mitral valve surgery, is really a lot of variation in the load condition, and on an impaired ventricle that cannot necessarily tolerate that very easily. How do we decide and dissect this hemodynamic situation? We tend to use cardiac output monitoring, and this is here the very unpopular pulmonary artery catheter that we tend to use despite its bad press. It can give us a measurement of the cardiac output using thermal dilution method and therefore calculate the peripheral vascular resistance. On top of that, there is pressure monitoring that gives us an idea of what's the preload because it measures pulmonary artery pressure and wedge pressure, and on the other side, the central venous pressure. Obviously, the PA-Catheter is only a monitoring device, and it's got very bad press because it needs to be interpreted very carefully. There's a lot of mistakes that can be made by just reading pressure numbers. But it's still useful because it acts as a warning device. Obviously, there's a lot of things that can happen during the immediate postoperative period. Fluid shift, variable demand, variable stress, variable load condition, and evolving response to the injuries that develops and change over the course of the few postoperative hours. PA-Catheter certainly is going to act as a warning device, but also going to be very useful to assess the response to all of our intervention. But it needs to be remembered that it only provides very surrogate information. It's only a pressure monitoring device, and we know that the relationships between pressure and volume are in fact very complex, and any attempt to derive chamber volume and contractility from pressure values is a very dangerous and very often misleading attempt. Mitral valve surgery is in fact a very good example of pulmonary artery catheter failures, and where echo can actually unravel otherwise very difficult to diagnose complications. Right ventricular failure and right-sided problem are a very good example. The filling pressure can seem low with a low stroke volume, significant respiratory variation, and at the same time a high CVP that's very hard to interpret because there is significant TR. And that's a good situation where the relationship between pressure and volume or function should not be guessed too hard. In fact, echo is virtually indispensable here to identify the right-sided problem and differentiate between RV failure and tamponade. That doesn't mean that all the pressure monitoring is good for the rubbish. It just means that you need to use them not as a number provider, but more as a pattern provider, where you have a look at the trace much more than the number it gives you. Anyhow, there's a very large number of reasons for the right ventricle to fail in the postoperative period, and they often all combine. Again, long pump time, large volume fluid and blood products that the right ventricle is going to have to accommodate. Right coronary ischemia, either because there is right coronary perfusion problem, or also just because the right coronary is actually sitting very upward and is a privileged site for any air embolus at the end of the procedure. But also many patients, when they come to mitral surgeries, actually present with long-standing pulmonary hypertension. And they in fact have a very reactive pulmonary vasculature. And together with the effect of mechanical ventilation and sometimes superimposed lung injury, acute lung injury with associated pulmonary hypoxic vasoconstriction. And certainly the right ventricle is very highly sensitive to acute afterload increase. Right ventricular failure is a very serious and very difficult to treat complication in intensive care. Unfortunately, there's no good inotropic medication that works very well or very specifically on the right ventricle. Maybe levosimendan has a preferential role in this context for difficult right ventricular dysfunction cases, but there is only limited evidence to support that. In fact, the true pulmonary hypertension crisis is not uncommon after mitral valve surgery, and the strategy has to be directed toward afterload reduction and coronary artery perfusion at the same time. Again, the right ventricle is very sensitive to afterload, and the treatment has to include pulmonary vasodilator if really there is a true problem of pre-capillary pulmonary hypertension. Probably any vasodilatory drug would work if they injected from the pulmonary artery catheter, but preference is typically given to inhaled pulmonary vasodilator. This is because they would reduce the effect on systemic blood pressure and therefore the potential deleterious effect on coronary artery perfusion, but also because there is true advantages in terms of VQ mismatch and gas oxygenation. Available option commonly used would be nitric oxide or inhaled prostacyclin, or even inhaled milrinone, really depending on the local availability and preferences. Fluid management and preload optimization in the situation of right ventricular failure, it becomes in fact very difficult. Typically, the acute RV failure is a situation where there is a very big right ventricle with a severe TR sitting next to a small and empty, sometimes hyperdynamic left ventricle. And certainly, fluid overload and congestion is in fact part of the problem. And just thinking of the RV failure as a situation that needs just ongoing and continuing fluid resuscitation is certainly not the easy answer. But this is typically an area where everyone's going to know better than the others, and this is really because there's no straightforward monitoring device that can help define the target for fluid therapy in this situation. Obviously, the right ventricle, that's not the only potential victim, of course, and the left ventricle can also come across a lot of problems too. The left ventricle, again, is very abnormal to start with, and can be submitted to and subject to ischemia, myocardial edema, and again, increased demand or eventually acute valvular problem after the operation. The situation of mitral valve, of surgery for mitral valve regurgitation is probably quite particular in a sense in terms of acute afterload increase of the left ventricle. There is this probably partially true concept that the mitral regurgitation pre-op provides some sort of escape valve for the left ventricle to offload some of its stroke volume toward a low pressure system, which is the pulmonary venous system. And obviously all that disappears, and this escape door is abruptly interrupted after the procedure, and this is equivalent to acute significant rise in the left ventricular afterload and the demand of the left ventricular afterload. And this could be one of the reasons why the left ventricle is failing. But hopefully, a large proportion of ventricular systolic dysfunction is in fact due to reversible factors, and hopefully they will improve. And that basically justifies the use in the acute phase that it can be supported with inotropic drugs. This could be milrinone or dobutamine. Many people like milrinone because there is a lot of afterload reduction effect, and maybe also because some would think that there's a bit less arrhythmia induced by it. Those drugs are typically starting during operating theater and continued in ICU, and they will be titrated during the ICU following the values given the pulmonary artery catheter. But obviously, those postoperative ventricles, they're very fragile, they have very narrow therapeutic intervals, and really the question is what target we should use to decide on the level of inotropy that we're going to use to push the left ventricle. And we now stand quite distant from the idea that the more cardiac output, the better, especially when the need is in fact completely unknown. Instead, we try to adjust the goal to the idea of adequacy of tissue perfusion. One of the best index is probably mixed venous saturation, which we tend to use quite a lot, and where basically a sample of blood is taken from the PA-Catheter, and oxygen saturation is then measured. And this is a representation of the balance between oxygen delivery, which is directly proportional to cardiac output, and peripheral tissue extraction, and therefore adequacy of oxygen delivery. We also rely, obviously, on organ function, such as renal function or liver dysfunction being a very sensitive sign of right ventricular dysfunction. Lactate and acid-base balance is another important component, but we understand more and more now that the relationship between lactate and tissue hypoxia is, in fact, very indirect and very much multifactorial. At the same time, we know that there is potential harm from inotropic stimulation. This is in fact quite established. Also, it's been described in many situations that are not immediately related to postoperative period after heart surgery. Stress-induced cardiomyopathy is increasingly recognized in critically ill patients, and certainly there's a lot of situations where the lack of benefit from inotropic stimulation has been interestingly shown. This is the case of all the recent sepsis trials where we thought that pushing up the cardiac output and oxygen delivery would help preventing organ dysfunction, and this has all shown very disappointing clinical results. In fact, even further, there are some benefit of beta blockers that is in fact proposed to be extended to situations that were previously thought to require supraphysiological stimulation. Again, that's the case for sepsis. Anyhow, levosimendan was a drug of hope because it comes from a very nice world where it was supposed to increase myocardial efficiency, basically augment myocardial contraction without increasing oxygen consumption. But as you know, the result of all the major trials have put this drug in a much more disappointing sort of position. Talking about the toxicity of inotropic support, and more specifically about the beta stimulation, that leads us to another aspect of cardiac complication that's quite specific to mitral valve repair. And this is obviously the displacement of the anterior mitral leaflet and the development of SAM. It's been quite detailed in the previous talk. But certainly that would produce a hemodynamic picture that will be one of the rising filling pressure, pulmonary hypertension, decreased cardiac output. It's a situation that's very important to be recognized in the postoperative period, because the temptation to increase inotropic support would be very deleterious. In fact, that would actually worsen the situation. In fact, the beta stimulation needs to be reduced, and the inotropic choice needs to be changed to a drug with minimal beta effects, such as vasopressin or phenylephrine. Even beta blockers need to be considered. Fluid therapy is as well advocated, despite the presence of mitral regurgitation in an attempt to re-expand the ventricular cavity. Bedside echo, again, here plays a very central role, and it has this unique capacity of dissecting complex clinical situation and gross valvular function. Indeed, one of the key aspects of the postoperative period after cardiac surgery is its very dynamic picture, and in fact, the echo picture can change a lot over a short period of time as the load condition change. Ejection fraction and chamber size, they're eminently load dependent. It's actually very common to receive a patient coming from theater whose toe at the end of the procedure was said to show a very good systolic function, but this happens at the time where he's weaning off the bypass, where there is a massive surge in the catecholamine response, where the afterload is probably markedly reduced and the patient is anemic. But only a few hours later, repeat echo would demonstrate quite a markedly dysfunctional left ventricle. Anyhow, it's quite important also to remember that left ventricular dysfunction, as assessed by echo, can be very difficult to assess properly and to characterized well in some situation, and in the same situation where the ECG is in fact absolutely not helpful because of all the conduction abnormality or eventual pericarditis. The typical echo picture of the ICU patient after mitral valve surgery has got a paradoxical septum, and some segmental wall motion abnormality can be seen. This is in fact typically the case after at least some case of mitral valve replacement where the anterolateral chordae cannot be reinserted, and that produce an anterolateral segmental abnormality, or at least mimics a segmental abnormality there that shouldn't be mistaken for a coronary artery problem. But back to our patient, he has stabilized, he's remained on the ventilator, he now needs to be extubated, and of course that can be the next problematic step. At the time of weaning off the ventilation, typically the patient has received a lot of fluid and sometimes a lot of blood products, and he certainly comes from a short period where there was a lot of stress, and his natural tendency was, his humoral response was to produce a lot of fluid retention. But as the inflammatory response will start to come down, the tissue edema will be recruited, and the demand on the heart will start to increase. Typically, the patient has gained at this stage 5 to 10 kilo in fluid weight, and that will need to be dealt with by a properly functioning heart. The positive pressure and the P provided by the mechanical ventilation, in fact, they are a very important component of left ventricular support. This is because they reduce venous return, but also because they reduce the transmural left ventricular pressure gradient. And this is a mechanical left ventricular support that will sometimes be very difficult to wean off. And this is probably an area that kind of overlaps with the concept of diastolic problem. At the same time where atrial fibrillation typically becomes a major issue again. And therefore this phase typically requires very generous diuretic treatment. Unfortunately, there is no good echo criteria to optimize the assessment here, and the diastolic echo parameters are rather not applicable in this situation after mitral valve repair and the critical situation. Other problems that the patient will have to face is obviously pre-existing lung disease, a lot of pain with poor cough, poor respiratory effort, sometimes airway problems, but also direct lung injury, either from the surgical trauma or the pre-existing pulmonary edema that can transform into true ARDS sometimes if the operation was rushed in a very urgent indication. Diaphragm dysfunction needs to be reminded because there's always a risk of direct phrenic nerve trauma, as well as pleural effusion, of course. The last line that the patient will have to jump across is the potential for neurological complication. And that can be a disaster, and that certainly can range from extensive brain damage, from extensive stroke, to much more diffuse and subtle brain problem and cognitive dysfunction that can unfortunately be extremely debilitating. This is presumably the result of acute illness, the effect of the bypass pump, and maybe some microbubbles that embolize diffusely into the cortex, and the effect of all the drugs received. Delirium is unfortunately very common, but unfortunately in intensive care there is no such thing as neurological replacement therapy, and the complication in this area unfortunately call for very limited options. But eventually the patient will become ready for the ward. The challenge here is to restart anticoagulation and antiplatelet drugs, stabilize all the pre-existing comorbidities. This is typically the case for pre-existing diabetes and obstructive sleep apnea, and then restart all the antiarrhythmic and heart failure prevention treatment as soon as the blood pressure permits. And then he gets welcome on the ward with the same big smile as he's just had a few days prior. Thank you.